Basically, guys, hydatid mole represents as the first trimester bleeding. We have four causes of first trimester bleeding: any sort of threatened abortion, ectopic pregnancy, like some cervical cancer, cervicitis, and hydatid mole. Okay, it's abnormal bleeding, and this is going to cause it can have the hydropic tissue, plus minus, and this is going to be enlargement. The enlargement of the uterus more than the gestational age. So the mother might have like last menstrual period 6 weeks ago, but the uterus is 12 weeks. And there's going to be very high HCG, and theca lutein ovarian cyst will also be there. We can have a lot of vomiting, hyperemesis gravidarum, and we can get preeclampsia and some features, and this hypothyroidism. This is very interesting. Why we're going to hypothyroidism? Because beta HCG, its subunit is very similar to TSH, so that can kind of stimulate the production of TSH. We can see over here the risk factors is going to be for example, extremes of age, any previous history of hydatid mole. The ultrasound is going to show a snowstorm appearance, and as we said, high BCE beta HCG. Histology will show uterine contents. Histologic uterine, we have to manage with dilation and the DNC, and we have to do serial beta Z after beta HCG after evacuation, and we have to do contraception for 6 months. Okay, I have a very important question over here. Basically, there was a 41-year-old female. She comes with 4 months of amenorrhea. She has hypothyroidism, so tachycardia, diarrhea, all those symptoms, palpitations, sweating, increased heart rate and vasomotor symptoms, and enlarged uterus and beta HCG. What's the diagnosis? Diagnosis of hydatid mole, and I was thinking of struma ovarii. That's not the scenario over there, because we're going to have amenorrhea plus hypothyroidism, so we're thinking about hydatid mole. Guys, it's important to know the difference between complete and partial mole. Okay, guys, partial mole and complete mole. What's the difference? Complete mole, it's going to be 46XX. Okay, it's going to be 2 spermatids. Partial mole, it's going to be 69XXX. Okay, like that, 6XX, and that's going to be 2 sperms plus an egg. Okay, in the complete mole, it's complete a mole. So they only have the hydropic villi and trophoblastic stuff, no fetal parts. Partial mole, we're going to have some fetal parts. Of course, complete mole is going to be increased uterine size, increased HCG, and we can see over here there is going to be maybe 15 to 20% of becoming invasive, 2% of being cancer, whereas partial mole does not have a ability to become invasive, or very low chances. Alright, why we want to give contraception, guys, to these patients? The reason is that the risk of having another molar or pregnancy is low. But once you have a contraception for 6 months, so you might want to wait 6 months to a year. The risk of having another molar pregnancy is low, but it's higher once you have a molar pregnancy. So you want to chill out for a moment. Okay, and then the guys over here, then the next point is going to be a management of hydatid mole. Management of hydatid mole can be suction carriage, weekly beta HCG levels until they become undetectable, and we're going to have monthly beta HCG levels for more than 6 months, and we can then do surveillance to completely attempt pregnancy, and then we can see diagnosis of the trophoblastic tissue. Okay, so guys, got some questions over here, which I wanted to share with you guys. So there was a 32-year-old female. She's 16 weeks, born to the ED with vaginal bleeding, palpitations. BP will be quite high, and the uterus consistent with the size 20 weeks. She's anxious and flush, and they will be 10 centimeter cyst at adnexal masses bilaterally. What's the next best step? So just do DNC and weekly beta HCG monitoring. Okay. If the pathology shows hydatid mole, what's the next best step? After suction carriage, we have to monitor weekly, and then we can go monthly. So monitor weekly over there. Then over here we also have another one with if she has a lot of spotting, and there's some sort of amenorrhea. Urine pregnancy test is positive. Where we can think about choriocarcinoma, and we don't think about incomplete abortion, because incomplete abortion, it's going to be an open dilated cervix, and there's going to be bleeding as well. Okay, so guys, time to recap this page. So I want to start off with this hydatid mole. Guys, hydatid mole, think about some hyperthyroidism because of beta HCG. Think about a really big uterus size, and think about some amenorrhea and some vaginal bleeding. Okay, risk factors is going to be any previous hydatid mole, any sort of extreme age. ultrasound show the snowstorm and very high HCGs. Treatment is going to be with DNC, and if you do weekly monitoring. Contraception for 6 weeks. Complete versus partial, guys. Complete it's going to be only mole. It's going to be 46XX. Partial is going to be fetus plus mole. Okay, partial fetus plus mole, 69XXXX. Okay, so guys, we can see we're here with this in hydroniform mole. Do weekly BDHCG, then go monthly for 6 months, and then we can just do surveillance. So that's just mole made very simple. Hopefully you guys found this video useful. Hope to see you guys next time.